Hi, I'm Dr. Andy Evans, Deputy Director of the Rutgers Cancer Institute and Medical Director of the RWJBarnabas Oncology Service Line. We're thrilled to be here at ASCO. We're actually at our Rutgers Cancer Institute and RWJBarnabas Health reception here along the Chicago River, which you can't see. But I'm really happy to be here with Dr. Saum Ghodoussipour, who's I don't even call you a newer faculty. It's been 3 years now. We're just thrilled. One of our oncologic surgical experts here. And he's got a couple really neat projects that are emanating out of ASCO and really impacting not just practice in New Jersey, but it sounds like internationally. But
Yeah.
Saum, let's maybe start first with the one project that you were looking at, a more radical surgery versus conservative surgery. A little bit about that project and what it's leading to.
Yeah, so this project is looking at patients who have upper tract urothelial carcinoma, the same type of cancer that's typically found in the bladder, but when it's found in the upper tract, either the renal pelvis or ureter, it's a little bit more difficult to manage endoscopically. So traditionally, if you have a big tumor up there, the treatment has been radical nephroureterectomy, which is removal of the entire kidney and ureter, which obviously has some consequences in terms of renal function, but also the morbidity of surgery in patients who are older and have a little bit more complex medical history. It becomes challenging. So we retrospectively looked back at our series of patients with high-grade disease who were managed endoscopically. We believe it was just under 20 patients versus almost 40 patients who were treated with radical surgery. And we followed their outcomes. And we saw that, with 3 years of follow-up, the metastasis-free survival, progression-free survival, and overall survival were similar in the groups that we managed endoscopically versus those who were managed with radical surgery. Now, obviously, there's a lot of patient selection that goes into play there, and there's a lot of other variables like the burden of care and the number of visits you have to have. Patients who had kidney-sparing surgery had much more frequent visits to the hospital, as you can imagine, but they had a much lower complication rate, and they had a much lower rate of developing chronic kidney disease. Costs were similar. Total anesthesia time and number of days in the hospital were actually similar, because if you have kidney-sparing surgery, you have to have multiple treatments down the line. But, I think that the gist is that you can, save these patients from high-risk surgery.
And what's great about this is not only is this a retrospective real-world project, my understanding is this is actually, which is fantastic in itself, but then it's leading to a investigator-initiated study. Is that right?
Yeah, that's correct. So in the past, when we managed patients with kidney-sparing surgery, it was just an endoscopic ablation. But recurrence rates are common, and there is a concern for progression if you're not removing the kidney. So we think that there needs to be something more than just kidney-sparing surgery if we want to be able to offer this to more patients. So we do have some concepts for investigator-initiated trials coming up where we're actually going to administer intrarenal chemotherapy directly into the kidney. So not systemically, but just sort of topical. And that combined with the ablative therapies could lead to even better outcomes.
It's fantastic to not only do that retrospective real world, but then to turn it into something prospectively. And let's quickly maybe pivot to another really interesting topic of radical cystectomy with urinary diversion, which itself is a complex surgery.
Yeah.
And that's one critical part, but then maybe something we don't think enough about is, what about after that surgery? What's the care pattern, the standardization of that? And my understanding is you have a role in leading a international effort on this, guidelines?
Yeah, correct. So, radical cystectomy, which is removal of the bladder and then creation of a new urinary diversion, typically with bowel, the small intestine, is the standard of care for patients who have muscle-invasive bladder cancer, patients with non-muscle invasive disease that has failed prior intravesical therapies, and patients who have failed treatment with chemotherapy and radiation. So, one of my favorite things about coming to ASCO as a surgeon is I get to learn so much about, the systemic therapies that are in development and all, the non-surgical managements. And today there was a really nice session on chemotherapy and radiation, as well as systemic therapy in those patients with avoiding cystectomy. And the reason people are so motivated to avoid cystectomy, even though it is a curative procedure, is that it's very complex. The 90-day complication rates are almost 70%. Length of stay in the hospital has been up to 10 days. And it's a lot for patients to go through in terms of quality of life changes with the urinary diversion. So enhanced recovery after surgery is a concept that has been around for almost a decade now, with guidelines that were published in 2013. And these are multimodal, multidisciplinary care plans that aim to optimize recovery for patients. So what we did was we looked at the National Surgical Quality Improvement Program, which had almost 4,000 patients who had radical cystectomy. And in 2019, they published a targeted data set that had a lot of individual variables in patients who had cystectomy. So we were able to look at things like initiating an early oral diet, which is a new concept. In the past, it was dogmatic to not feed patients after surgery, to give venous thromboembolism prophylaxis with anticoagulation, to give regional anesthesia blocks to avoid narcotics, things like that. So we queried that database, and we were able to see that the more interventions you adhere to, the better patients did.
And then lastly, as part of that, great for us in Rutgers in New Jersey, but to really have a role on international standardization, right?
Yeah, so those guidelines were published in 2013 by the Enhanced Recovery After Surgery Society, which is this international group that was established in 2001. But those guidelines have not been published or updated since 2013. So I'm fortunate to work with a group of international experts and leaders, much more advanced and I would say accomplished than myself, but I've learned a lot working with them, and we have an updated set of guidelines, over 4,000 papers that were reviewed, and it should be coming out this fall. And I'm happy that Rutgers is a lead part in that.
Fantastic. Have a great meeting, Saum.
Thank you.
All right.